Good afternoon. We've had talks in German with German slides. We've had talks in German with English slides. Now I'm going to do English talking with English slides. I do apologize, but and thank you very much to Peter Kolominski and the team here in Erlanger, and to all the colleagues I've worked with, particularly Peter and Marcus. Nice to see old friends again. So what I'm going to be saying is, you probably heard this afternoon already, but I'm bringing it together because we still fail to take stroke seriously at a country level and globally compared to other diseases. It's somehow forgotten, although it's improving with improved evidence-based interventions such as stroke units, thrombolysis, thrombectomy. We're doing quite well. But as we heard 2 talks ago from Michael, stroke is a long-term condition, and we haven't got that right. And so this is really about what is the impact of stroke and what can we do in terms of policy as a result of that. Unfortunately, about 80% of strokes are preventable. So we read papers saying, we're treating blood pressure, we're giving people patches and they're stopping smoking and diets have changed. Well, they haven't really. And if you look at the data, certainly the slides show a decline in all sorts of things such as risk of stroke, death from stroke. That is beginning to plateau. And in some places, for people aged over 40, it's increasing again in Europe. And so I think, we wait and see what happens in the next 10, 15 years. But certainly, it's quite sad that prevention is really still not much more advanced than it was perhaps 20, 30 years ago. We still don't detect. We give treatments and we think that's fine, but actually people may or may not take their medications. They might have other priorities, and then they may have other conditions. And so we have to really get underneath all of that. And that's where patients and stroke survivors, really, really important to understand some of these barriers. So I'll give you some of the journalistic global sort of figures. This is from the Global Burden of Disease, which is really getting data such as the Erlanger Stroke Register, registers around the world, and quality improvement registers, and routine data, bringing it together in different ways in different countries. So there are many, many faults with it. But it does show, and this is the last cut about 10 years ago. And you can see with the different colours around the globe that in fact the risk of stroke varies considerably. And in different countries that will be due to different things. It's not all about cardiovascular risk factors. Increasingly it's around things such as poverty, migration, war, other things, the stresses, and the financial issues occurring in both in rich and in poor countries. Those things we cannot measure well, but they're all bringing together what are the inequalities in stroke in globally. So the risk of stroke does vary considerably, but it is on the increase. The next thing is really looking at the disability from stroke. We've heard about it's a long-term condition for stroke survivors when they survive. And it's the most common cause of physical adult disability. We don't, politicians won't understand that. People who run healthcare systems may, but they perhaps don't pay as much attention to that as they do to the sexy new drug or the sexy new robot or the new app or whatever. I'm just being provocative to make you think about, we have these data, but these data are not used intelligently to understand equitable care for people that have a disability. So you can see that over the next 15 years, the number of people who have stroke, who have disabilities will increase, mainly due to an aging population. And that aging population is really quite concerning. So what's happening? So we've heard a little bit about the Stroke Alliance for Europe, bringing together people who run health systems, patient groups in different countries, and we've worked very closely with them on several fronts, and to look particularly at what the impact of stroke is. And it's really to provide that public awareness of stroke for all the different stakeholders involved, to really provide education around stroke to not only survivors and families, but also to clinicians and to the general public, and supporting research in the right areas where there are big gaps. So, from my perspective, there's a lot of research in the front end of stroke, which has been fantastic. We now need to think about the balance and think about long-term stroke. And so that supportive alliance has been very instrumental in getting clinical groups and different governments to take action and write down strategies. The trouble with strategies is they only last as long as a government, and most governments on this planet are changing this year. And so whether they will be put on the filing cabinet or whether they'll be taken forward. So we need to champion it. So the, I don't know which slides come up, sorry. So all countries are involved, and not just necessarily just European. And we've certainly done some work and had translated into all the languages of these countries, something to bring together all the literature on estimates of the impact of stroke, incidence, prevalence, mortality, some of the issues around health economics, and then long-term care, and made suggestions with the Stroke Alliance that we have taken to government. We've been to Brussels several times, and then within each country's leaders have talked with ministries of health and social care about what to do. And I really want you to look at the slides on these here. So incidence, but over the next 20 to 30 years, is going to increase, as I said, mainly because of aging, but also within low and middle income countries, the taking on of particularly more sort of Western style diets and McDonald's and things like that is certainly contributing to some of this. And we can't quantify the effect of climate change in these different settings, and also the effect of migration. The prevalence, the number of people who are living with a stroke will also increase. This will have huge effects on the healthcare system and the social care system and the families. And this is, I think, the area that's been mainly neglected. And the death rate will increase again. So the data are terrible. We may think we're doing really well, and we are doing fantastically. And it's a long course that we have to take. But I think it's how we speed it up, or how we get buy-in from the people that can make the decisions that will be important. So a summary slide from this report, in which most governments in Europe have been given and has been fed down, is we've heard about the figure before. The estimate of the total cost of stroke in the EU of 45 billion in 2015 is set to rise, we know that. 34% increase in the number of people who have strokes, we've talked about that. And so it goes on. And particularly, I think, the last one, the number of people living with a disability will increase by a third. So they're quite stunning. So all this will have effect on all of us, and it needs to be dealt with now. So the key findings really from this report, which were reports from different countries, was there are disparities or differences between different countries that we need to take account of, and certainly been neglected to some extent in all countries. Little bits. Some focus on one thing, some focus on another. So what is it that's good and bad? I'll focus on what people are comfortable with in terms of perhaps some of the acute stuff, and look at what we say a less good service, or a bad service, or a good service. That's my car, by the way. And so it's a question of, and the dog is now dead. So, so it's a question of, where do you think the services are in your part of Germany? And they'll be different for different aspects. Most people have a stroke unit, but how you get there will be variation. What happens when you leave? Complete chaos everywhere, I think, in the world. Apart from maybe someone says, no, my service is good. but my service only deals with 10 people. So it's all very, very tricky. But you can do all sorts of interesting things that hit the headlines, and this thing even came to London, to City Airport, the mobile telemedicine ambulance, which was Berlin, and it's very good because it can get very quickly to see a patient. They have a scanner in the van. Why would you need that in the middle of a capital city? And it's prone to being bashed by other cars and all sorts of things. But it may be useful in where there are less dense populations, so in rural areas, in the countryside, potentially. But no evidence of cost effectiveness, I think, is an issue. Some slides from the projects that Peter Kolominski talked about. Most of you will recognize the sort of normal things you will see for stroke care in terms of clean buildings, everything else. But in Dijon, they have a helicopter. Again, very interesting, donated, cost a lot of money, probably very good for rural, and as long as he hasn't had some burgundy and this sort of thing. But I think there are certain things that people will put money into and then neglect the other things. Or you go to the other extreme. The slide on the left was the premier stroke unit in St. Petersburg about 12 years ago. And that was the stroke ward where I think it was George Bush would have gone if he'd had a stroke when he visited Russia. But they decided it was quicker to get a helicopter to Finland rather than go on that ward. So that was the best. And that compared, about a week later, we went to the Karolinska, and you can see it's like IKEA, and it's a fantastic rehabilitation setup. But, it's probably not quite in the right place. I remember there's one study we did with all of us in Italy, just near Florence, where all the rehabilitation hospitals are on top of a hill. They're quite nice big buildings, but people could not access them. It's really difficult to get to them. So we have to think about all of these things. Another thing we've done with SAFE is to look a little bit more at what Michael talked about, the unmet needs of stroke survivors. Still not well described, but the Erlanger Stroke Project, our project in South London, other registers have data every year on the needs of patients, but they also have their demands as well. So there are family stresses, there are issues that some health insurance companies in different parts of Europe are just not funding this type of care, and some governments, most governments are not aware of what the issues are. Therefore, because we can't explain it easily along the pathway, it's difficult to invest in. And what do we invest in? The evidence base is not good. People say they want rehabilitation, but the evidence for long-term rehabilitation after a year is not good, but the demand is there. And the supply is not possible because we haven't got enough therapists to deal with it. So there are all sorts of things. So this slide was from a survey we did in each European country as part of this report. And most of this is from the literature. And the things that came out were not what I really thought would be the issues. So sleep disorders, and you can see each of them has a very wide range of averages. We couldn't pool the data because every study virtually uses a different scale. And it's therefore very difficult to pull it together. So sleep disorders, sexual dysfunction, high blood pressure, which we've heard about a lot, is up there. But as you can see, there's a lot of things that perhaps the medical eye would be less focused on, and perhaps the family eye. So the most common problems are probably neglected. But from a patient and carer perspective, it was very different. They wanted more rehabilitation. We talked about that. They wanted something to help their memory and concentration, and they wanted to have fatigue sort of managed some way. So you can see all these things that perhaps are not central to what the current medical, nursing, rehabilitation staff will do. So there are mismatches that we need to iron out. So SAFE decided on a plan of action, which was what you might expect, to understand some of these issues much more, and for everyone to be followed up every year. Now, I would question about why every year and what you're going to do, but don't forget people. Keep seeing them, because there will be something that you'll be able to do. And the good thing about registers is they're probably one of the only stable points of contact for a stroke patient every year after their stroke for many years, and they look forward to the visits. So there were lots of recommendations from SAFE, and it's all on their websites if you need that. So bringing all that together, there's a stroke action plan for Europe, which really involves SAFE, and it involves the European Stroke Organization, some aspects of the World Stroke Organization, and bringing in some governments. And there's sort of things that you'd say, yes, we need to do that. Reduce the absolute numbers of stroke. It's very easy to say that by 10%, but we've shown that 80% are preventable, but they're still happening. That everyone is treated in a stroke unit. And I think we're getting there in most countries. We're there, but national plans for the whole pathway. That, I think, is where the focus needs to be next. Once you leave hospital, what is happening? How's that going to work best? How do we set up research to identify the best way of doing that? And how do we, exactly as Michael said, how do we get multi-sectoral involvement from all stakeholders to make this really work? So the plan is around, it's like, one would all say this, but it's from primary prevention right through to life after stroke. And that really will require developing policy at a national level, and I think that's happening. I hear from you about whether it is or isn't happening in Germany or in the different regions of Germany, but certainly locally as well, and perhaps some examples locally that feed up would be really important. So you get patients, you get the health insurance, you get the policy makers, the doctors, the nurses, the therapists, etc., all together. So thank you very much, and I'm sorry I wasn't speaking in German.